Good morning or afternoon, everyone, depending on where you are. This is Kat Eaton with JBS International. Thank you for joining today's webinar on Building Trauma Competencies with Dr. Kelly Graves, Karen Yost, and Jenny Cole-Mossman. Before we begin, we'd like to review a couple of housekeeping items. All participants in the webinar will be muted for the duration of the presentation. However, we still want to hear from you. If you have any questions or comments, please submit them using the chat feature. You can open your chat window by clicking on the chat icon located at the bottom center of your toolbar window. We will continuously monitor the chat throughout today's webinar, but the presenters will not address comments and questions until the end of the presentation. This webinar is being recorded. The recording and presentation slides will be made available to the OVC-TTA mailing list in the coming weeks. If you experience any technical issues during the session, please message us using the chat feature or email us at ovc-tta@jbsinternational.com. There will be a link to a post-event survey sent in the chat at the end of the presentation, as well as emailed to all registered participants in the coming days. We would greatly appreciate it if you filled it out, as this will support future development efforts. Today's webinar provides 2 hours of National Board of Certified Counselors and the Association for Addiction Professionals credits. If you are interested in earning these credits, you must fill out the post-event survey to qualify. Additionally, please email your name and email address to ovc-tta@jbsinternational.com, stating your desire to qualify for CEU credits, and provided you have filled out the post-event survey, a certificate will be emailed to you in the coming weeks. Now I'd like to turn things over to our experts for today.
Good afternoon, everyone. My name is Kelly Graves. I'm the Executive Director and co-founder of the Killen Foundation, which is a nonprofit in Greensboro, North Carolina, serving the state and connecting in with some national work as well. I'm a clinical psychologist by training and look forward to diving into this discussion with everyone today.
Good afternoon, everyone. My name is Karen Yost. I work for JBS International. My background is in behavioral health and specialize in trauma and trauma-informed care. It's nice to be with you.
And I'm Jenny Cole-Mossman. I'm a licensed therapist in Nebraska and work for JBS International. And we're looking forward to getting through this with you today. We know we have a lot of content to cover, so thanks for joining us.
The objectives today will be to provide information about trauma, polyvictimization, and the basics of screening and assessment, describing key ingredients of trauma-informed care, evidence-based practices, drawing from key core components in the HOPE scale, and then ultimately to provide this presentation to be used by grantees in their community. So it is designed to give you a tool for educating your community. Next slide. I'm going to talk about trauma and what it is and its impact. And I'm going to go through some of these slides very quickly because we understand clearly that many of you have been working with trauma as part of your grant. So some of this is really we're just going to gloss over it because we think you understand it. However, when you use this in your communities, you may want to focus a little more on each of the slides. Next slide, please. So trauma isn't always a diagnostic category, although we do understand that there are many effects of trauma that do meet diagnostic criteria in the DSM, but it is really more about an experience or a series of experience that elicit certain feelings in us, and they result in survival-driven behaviors, thought, emotions, and needs. And there's no real universal definition of trauma. It is defined by the person who's had experience. And this is really important because when we talk about diagnostic categories, these diagnostic categories really generally don't capture the full sequelae of trauma, the traumatic experience, or the impact of that trauma. So you do have some commonality in symptoms and signs, but it really doesn't cover the true magnitude of trauma. Next slide, please. So simplified, trauma is about an event, it is about an experience, and it is about the result of that experience, what impact it has on the individual. And so all three of those really together constitute traumatic experiences. Trauma changes the way people view themselves, and others and their world. And it can impact health, safety, and well-being of an individual. Next slide, please. Now, there are 2 slides on prevalence, and I'm not going to go over them except to say to you, we understand that you probably have knowledge of prevalence, but when you use this training in your communities, you can use these slides, or you can tailor them to your use. For instance, when I trained schools, prevalence data that I used was related to schools and what's learning and student behaviors. When I trained primary care, the prevalence data I used was geared more to primary care things, physical and all of that. When I trained homeless service providers, my prevalence data was related to them. So this is really 2 of those slides that you can change to fit your needs. But we gave you some general information just to highlight the prevalence of trauma. Next slide, please. And you can see again, overrepresentation of youth and adults of color in the justice system, significant exposure to trauma and violence. Children with abuse and neglect, are more likely to be arrested. And you can just talk about some of those things when you do your training in your communities. Next slide, please. We know from research that there are certain groups of people who are more vulnerable, and you can see these listed here. We know a lot of the work, what we know about trauma really began with veterans. It is not new to the veteran community, and it was called many things. It's called shell shock and battle fatigue, and it really wasn't until after Vietnam that trauma was really begun to be explored relating to veterans. Now, these aren't the only individuals who are vulnerable to trauma, but as groups they are. And think about what other vulnerable populations do we have? And I think about now we're starting to see increasing trauma in first responders. Think about after 9/11, think about how we reacted that event. So this is not all of everybody, but it changes over time. Next slide, please. These are types of traumatic events. And the reality is most individuals have experienced traumatic events in their lives. It's very rare if you haven't. Some examples: loss of a pet, loss of a parent, bullying is on the rise, cyberbullying, and the social media has made that worse. Certainly all of these events are traumatic, and it's more unusual that someone hasn't had a traumatic experience in their lives than it is the other way around. Next slide, please. So exposure, again, caused by event, a connected series of events, or multiple unrelated events. It isn't just one or, it could be any of those. And we also know now, based on research, that trauma is underrecognized and underreported. Next slide, please. So here are some types of trauma. Acute trauma is a single traumatic event that may be limited in time. Could be a flood or a natural disaster or the loss of a pet. Chronic trauma is an experience of multiple traumatic events. Don't have to be the same event. So it could be multiple things. And I'll give an example of a flood, which I'm from West Virginia and we have a lot of floods. So you can have a flood which can basically, destroy a town, as it did in my case. But we also lost, as part of that, we lost our belongings. So we lost our baby pictures and those things that were important to our family. Complex trauma means that you've had both exposure to chronic trauma and the impact that an individual has is noticeable. And then finally, we have what I call system-induced trauma, and that is the impact of interaction with child-serving systems whose policies and practices create additional trauma. Example, traumatic removal from home, multiple placements within a short time. The systems that are designed to protect our children can also be re-traumatizing. Next slide, please. Trauma can occur at any age, and it can impact anyone. We are all susceptible to traumatic events because that's what life is. Next slide, please. And what trauma can do to us. It can interfere with our development, our physical, our emotional development. And over time, our capacity to integrate sensory information, emotional, cognitive information into a cohesive whole can be disruptive. And that sets the stage for additional responses to subsequent stress. So our body reacts to stress, but over time it takes a toll. And so there's an important developmental component to trauma that we did not recognize for a long time. Next slide, please. So let's talk about trauma in the brain. And we know from brain science, there's a lot of just so much research in the past 20 years on the impact of trauma. And we know that it can have serious consequences for normal development of children's brains. And that birth to 6 age is really important for development of children's brains and sets the stage. We call it success by 6. And so anything that disrupts that development and disrupts brain chemistry in the nervous system creates pathways in the brain and triggers neurotransmission that communicates with other parts of the body, and it links behaviors, thoughts, and memories together so that repeated experiences create pathways in our brains that change the way we view ourselves and those around us in the world and the experiences that we have. Next slide, please. So we have 2 hemispheres of the brain, and there's crosswalk between those 2 hemispheres. And as a result of that, that's how we regulate emotions and manage fears and attention for learning, problem solving, impulses. All of these things occur because of that crosswalk. Well, when trauma disrupts that and that crosswalk doesn't work well, then it can change things like our IQ, our ability to regulate our emotions, how we interpret our experiences, and then leads to increased fearfulness and can reduce our sense of safety and our sense of protection within our world. Next slide. So memory also occurs in the brain. And I always say that trauma is a disorder of the mind. And this is how it works for traumatic memory. And I think it's really important to understand how memories are generated in the brain and how trauma disrupts that. So sensory information is taken into the brain, it's encoded, encoding, meaning threat, no threat, and it can be stored. And we can retrieve those memories as we want to. So in a non-traumatic memory, information from the senses comes in, the thalamus processes that information. Again, it's sensory, it's sounds and lights and touch and movement. The amygdala processes that sensory information and says, this is a threat, this isn't a threat. In a non-traumatic memory, it says no threat. So the hippocampus then, which is the essential structure in the brain for formation of memory and storage, the hippocampus says, okay, I have this information, there's no threat. It adds narrative and context to that and timestamps it to become a memory. And then that memory gets stored in the prefrontal cortex. And so we can pull from that memory when we want to, although we we pull from that, unconsciously as well. If you're driving down the road and you hear a song on the radio that reminds you of something from your childhood, that memory comes back automatically. So it can be done consciously and it can be done unconsciously. But for traumatic memory, it's different. In traumatic memory, information from the senses comes into thalamus. It processes it as all that sensory information. The amygdala processes the emotions related to survival and says, hold it, this is a threat. If it processes it as a threat, then it bypasses the hippocampus and the hypothalamus, which is the primitive part of our brains that are involved in the stress response. And that's where the hormones of adrenaline and cortisol get released. That's where either fight, flight, or freeze comes in. So the hypothalamus says, oh no, I need to protect this person. And so it then generates all those, the neurotransmission and the adrenaline and the cortisol that allows us to respond in threats. So then when it goes back to the hippocampus, which is continually trying to file away this memory, it can't do it. And so memories are not really stored in the prefrontal cortex. They're free floating in the cortex. And so when these experiences, when the sensory information comes back into, it gets generated again, it gets experienced as if threat is happening right now. And so they don't become memories that get filed away. Part of treatment for this is to help override that whole process for the traumatic memory to where it can be stored away in the prefrontal cortex. It's still there, it doesn't go away. It can be brought into play either consciously or unconsciously, but it doesn't have that experience of being a threat, which generates a stress response in the body. So it's really important that people understand how that traumatic memory plays in trauma. Next slide, please. So here it is very simply. Seeing, feeling, hearing, smelling. These are all sensory experiences. Trauma is about sensory experiences. And when that gets triggered in our mind, it activates our alarm system. And the response is if there is current danger. Whether there is current danger or not, again, the brain has encoded it as a threat. So the thinking part of the brain, the part that says, wait a minute, let's process this. That part of the brain shuts down and doesn't get activated. And the part of the brain that does get activated is the part that says, we need to respond to this danger. We need to respond to this threat. And so the fight, flight, or freeze gets activated. And so past and present danger become confused. And over time, the brain doesn't know how to distinguish it. So everything sensory that is the trigger from that trauma becomes a threat. Next slide, please. So in thinking about the impact of childhood trauma, again, the early years of a child's life are critical to the development of their brains and to mastering developmental tasks that they have to do. And trauma can disrupt that process. And so what we begin to see are cognition problems, impaired readiness to learn, difficulty problem solving, language delays are prevalent in childhood trauma. Physical health, eating, sleeping disorders, poor immune system, emotional areas, concentrating, trouble recognizing emotions, coping skills problems, feelings of helplessness, shame and guilt, Relationships, you see a lot of attachment problems, and we know those first few years are critical for attachment to caregivers. And that's why a lot of our work now in infant mental health is so important for these developing children. Relationship problems are difficult here. Inability to attach in early childhood leads to relationship and attachment difficulties throughout life. On the mental health side, we see a lot of anxiety in these children, depression, low self-esteem, post-traumatic stress disorder, obviously, can be present, and suicidality. But where we see a lot of problems with these children is in behavior. So they have poor self-regulation. Sometimes they withdraw. Sometimes they're very aggressive. Oftentimes poor impulse control, risk-taking, a lot of risk-taking among these children. Sexual acting out, higher incidence of adult pregnancy and drug and alcohol use among children who've been impacted by trauma. And again, about the brain, we see smaller brain size. The brain doesn't process efficiently like it does in a normal brain. Again, that impaired stress response, it gets activated a lot more than it does in children who don't have these traumatic experiences. And we know now that it can, in fact, change the gene expression. So even the genetic makeup can change over time. A lot of really exciting research on that. So the impact of childhood trauma can be in multiple ways. Next slide, please. So I'm sure all of you have heard of the ACE study, the Adverse Childhood Experiences Study, which was really a study of adults who had experienced adverse childhood experiences, 17,000 individuals, the CDC and Kaiser Permanente. And that study really gave us a lot of information about the impact of trauma throughout the lifespan, and helped us to understand trauma in very different ways. Some of their findings, 61% of adults had at least one ACE, and these traumatic experiences were a little more narrowly defined than we do now. At least 5 of the top 10 leading causes of death are associated with adverse childhood experiences. Women and several racial ethnic minority groups are at greater risk of having experienced 4 or more types of events. And the impact of that through the lifespan are the adverse childhood experiences impact social, emotional, and cognitive development and functioning, lead to adoption of high-risk behaviors. Those lead to disease, disability, and social problems, and ultimately can lead to early death. And I'm sure you all are familiar with this. Next slide. So from a physical health standpoint, 4 or more traumatic experiences can shorten the lifespan, life expectancy 20 years. We have heart disease, we see chronic lung disease, and of course some of that comes from smoking, which we have a lot of people who get upset, they smoke. Liver disease could be related to alcoholism, diabetes, particularly for those individuals that are emotional eaters and eat the wrong food, cancer, and immune diseases. And so we see these through the ACE study that individuals with adverse childhood experiences had a higher incidence of all of these physical health problems. Next slide. From a behavioral health standpoint, we see an increase in mental illness, relationship problems, particularly children who have experienced trauma in younger years, behavior problems, poor self-esteem, substance misuse, again, coping, because trauma overwhelms our normal ability to cope, and we find other ways to try to do it. So we see emotional eating, substance use, smoking, risk-taking behavior sometimes, and higher rates of suicide among individuals who've experienced significant trauma. Next slide, please. So here are some facts, and there are all kinds of facts, and I've changed this 400 times, and every time I add different facts to it. but looking at the higher incidence of lifetime history of depression, suicide attempts, alcoholism, COPD, and a male child with an ACE score of 6 has 4,600% increase in likelihood of later becoming an IV drug user. And if you look at these, what you will see is a lot of these are based on attempts to cope with these overwhelming feelings related to trauma, and the inability of the brain to sort these experiences and file them away because we keep experiencing them. So a lot of times, many of these high-risk behaviors are designed to either get away from something, so it's to avoid something, or to get something. And a lot of times, both of those are related to relief from traumatic experiences that are not understood and can't be coped with well. Next slide, please. So some additional considerations: developmental trauma, polyvictimization, and trauma caused by societal conditions. Next slide. So developmental trauma is defined as a combination of the traumatic event and disruption in attachment bonds with primary caregivers. Again, I've mentioned a couple of times the importance of childhood development and how trauma disrupts that. And what we see in a lot of these individuals, we see dysregulation in three domains. And one is the affective and the physiological. Second one is attentional and behavioral. And the third one are self-relational. Thinking about that slide I had, the childhood trauma that had all those different types of impact. And that's what we see from a developmental standpoint. Next slide, please. So what is polyvictimization? Polyvictimization refers to having experienced multiple victimizations that are not the same type. So for instance, a child may have abuse, physical or sexual abuse in the home, may be bullied at school, may be exposed to domestic violence or other kinds of family community violence. So it is very different from multiple traumatic events in a chronic nature that is the same event over time. These are different types of events that occur, multiple rather than multiple episodes of the same kind. The term polyvictimization was introduced by American researcher David Finkelhor, and he really, that was related to young people who've experienced a number of different types of victimizations at a higher rate than the average population over a period of time. And he began to notice that this was occurring. And so he found a way to describe that as polyvictimization. Next slide, please. And here are some conceptual models of pathways to polyvictimization. And I'm not going to go over all of them, except to say, if you look under the far to the left, as you're looking at the screen, there are 4 pathways: dangerous families, family disruption and adversity, dangerous neighborhoods, and then emotional problems. And all of those, any or all of those, can set the stage for victimization and ultimately polyvictimization. And you'll notice 3 of those, the first 3 are related to the environment. And the fourth one is related, is emotional problems that could also be related to the environment. And so it's really important to understand that the environments from which our children, where they're living, have a great deal of impact on this developmental pathway to polyvictimization. Next slide. And we also know from research, from Finkelhor's research, that we can identify particularly high-risk subgroups of children and youth who've been exposed to several types of victimization. because over time they are more vulnerable to subsequent victimization and trauma over time. And of course, we know that complex trauma is the trauma experience through multiple events over time. And what this does is this gives us information about how we need to respond to these children and what systems and services can we put in place to support them, and how do we work with families and communities to create those environments that are going to be less likely to be traumatic for children. Next slide. So looking at trauma over time, we have found out that there are a lot of other things that impact traumatic events, and that they're societal, sometimes societal conditions. For instance, intergenerational trauma is a concept that was developed to help explain years of generational challenges within families. It is how that traumatic experience is transmitted to the next generation. And so this is where sometimes we get the, we get the understanding that abuse in families is generational, because if that's the way mom was raised, that's the way mom raised me. That's where some of this comes from. And we know that some kind of common symptoms we see from intergenerational trauma are things like low self-esteem, depression, anxiety, insomnia, sometimes anger and self-destructive behaviors, because, I do it this way because this is the way my family did it. So this is what we see in some of these things. And it can be transmitted through parenting behaviors. It can be transmitted through changes in gene expression. Again, we talked about, we know that trauma can have an impact on genetic and how that gets passed to the next generation. And there are probably other pathways that we don't fully understand yet. So it could be biological, it could be social, it could be psychological, or a mixture of all of these, or how intergenerational trauma is transmitted. So that occurs within families. Collective trauma occurs within communities. For instance, 1977, my county basically was washed away by a flood. We had 61 feet of water in my hometown. And the house that I grew up in was totally underwater, and you could see nothing of the house from the air. And it was a mess to clean up. But what we noticed was the whole community, you could see certain behaviors in the whole community. They all seemed like zombies for a period of time. They couldn't get basic needs met. And we began to see that every time it rained, you could just watch the entire community respond to that. And so collective trauma is really the manifestation of a traumatic event on a group of people. Think about 9/11. And how many times did we see those towers fall? It was on the TV every 15 seconds. And we saw it. And what impact did that have on our country and the citizens? We'd not been attacked in our own country. And in thinking about what that response looked like, I was American Red Cross Disaster Mental Health, and I ended up responding to 9/11, as I have for floods and tornadoes. And one thing that you see that is very evident is that it doesn't affect always just one person, but entire collective groups, communities. And 9/11, it was our country. We were all impacted by that in different ways. And so that's collective trauma, it's groups. Then in historical trauma, what we're really talking about is trauma for certain groups of people who have significant traumatic experiences. For instance, African Americans and slavery. We also see that with our Native American population based on what happened to them years and years and years and years ago. And that historical trauma becomes part of their DNA over time. And it does get passed from generation to generation. The Holocaust is another example of that. And so that historical trauma, even though it may not be happening there now, although we still have much of that going on now, it's still within the genetic makeup of that population, those historical experiences. And so we know that we have the types of trauma, but the societal conditions in which we live can also have significant impact on that. Next slide, please. Next slide, please. I think we're stuck. Uh-oh. What happened? I can't hear you, Jenny.
I think Kat may have got booted off and then is coming.
Yeah, I think I just got booted. Is everybody still here?
I still see 59 participants.
Okay, let me share my screen again. I think my Wi-Fi just crapped out for no reason. We love it when that happens. Share.
Well, you know, as they say, this is live TV.
Okay, everything up?
Okay. Yeah, next slide, please. So this picture really expands the view of the cause and the impact of traumatic experiences. When we think about many of the things we've already talked about within the household, within the family, you know, things like homelessness and divorce and all those things that happen within families can be traumatic. But when that happens within a community that experiences poverty, poor housing, discrimination, racism, historical trauma, a lack of opportunities for families, food scarcity, when what's going on within the family happens within a community with those kinds of conditions, it just compounds that. But then when you look at the environment and you look at things like natural disasters, and we've seen so many more of those, and it seems like every day there's some kind of flood or volcano or earthquake, or and think about the pandemic and the impact the pandemic had on our citizens. Increased isolation, increased substance use. So all of those things are going on within the larger environment. And then in many cases, we have the whole issue with climate crisis, and think about what's happening out west with the climate change. And when you put all of those things together, it just compounds the impact of those traumatic experiences. And so we've had to expand our view about traumatic experiences and cause and effect from other things than just our individual personal experiences. Next slide, please. And so what we have is a perfect storm. So we have things going on within the household. We have things within the community related social determinants of health, and Jenny's going to talk about that a little more. And then what's going on in our environment. And all of those things together create that perfect storm for serious traumatic experiences and even more serious chronic impact of trauma. So what we've done is revisualized our ACE pyramid. And so we talked about historical trauma and the generational embodiment of trauma, that gets parlayed into social conditions and what that local context of the community is. And that then lays a foundation at times for what happens next in terms of the ACE pyramid. So you can't talk about trauma and not talk about the societal conditions that can either generate resilience or generate more traumatic experiences. Next slide, please. So why is it that some individuals can experience the same traumatic event and yet respond to it in very different ways? Not all children who have grown up in abusive or neglectful households, experience traumatic or chronic symptoms from trauma. So what causes that? What have we learned about that can help us mitigate those factors going forward? Well, because the impact depends on a lot of things. It depends on the individual's age, developmental level, how they perceive that event, how they process it. Depends on their perception of the event. Was danger faced, or was it just really something awful that happened? Their relationship to a victim or to a perpetrator, their past experience of traumatic events, adversities that they face following the trauma, the degree of their resiliency and coping, the presence and availability of others who can help and support them. So all of those factors really can change the way we respond to traumatic events, and they account for the differences and the variability in how individuals do respond. Next slide, please. So now that I have breezed through a lot of information about trauma, much of which you probably already know, and this is just a reminder, or maybe, something's been said a little differently, a new perspective, talking about what do we do about it? I mean, we know it exists. What do we do about it? Well, we really need to be screening for traumatic events. And what screening does, it determines if a traumatic event has happened, if someone has experienced that, and that may include loss. It can identify the presence of symptoms or traumatic reactions related to that exposure, and can give us direction that more comprehensive assessment needs to be done. Now, this screening process can be formal. It can be informal. You can use a screening tool, or it can be a more extensive kind of process. But there are some things that should be considered when doing screening, and that is going back to those difficulties, those symptomatology kinds of events that trigger why people come into treatment anyway. So anger, depression, behavior problems, substance use, they may meet the PTSD criteria. So those are sometimes the behaviors that trigger the need for assessment. Something isn't right here because we're seeing these things. And so a lot of times those will be the triggers for screening, but we have to keep in mind that they may be trauma related and how that plays out. Next slide, please. So what does screening process look like? And I think this is critical as we begin to work with individuals who've experienced trauma. And there are things we really need to do as we're doing screening. And the first is explain the purpose. Why are we doing this? What does it look like? The unknown always makes people uncomfortable. And so being able to say to children and families, this is, we need to find out some of your experiences and what's going on. Explain confidentiality and its limits. I've, worked with children and adults all my life, all my professional life, and I know the importance of confidentiality, but you also know there are some limits, and that needs to be explained, what those limits are. Explain results to the child and the family, including what you're going to do with this information. What are you going to do with it? As appropriate. Sometimes I've done many evaluations to determine, if abuse or neglect has happened in families. And there are some limits to how you do that and what you have to do, but in as much as possible, explaining the results is important. Thank the child and the family for completing this process, particularly if trauma or additional trauma has been closed. These are not simple, painless processes for children and families. And so we need to really thank them for being willing to share some of that information with us. And sometimes normalizing feelings and normalizing their trauma reactions. And I've done programs specifically for traumatized children and adults, and they think they're going crazy sometimes. They think there's something wrong with them. And so sometimes we have to reassure them that what they're experiencing is a normal reaction. It's the situation that's abnormal. And I've always found that to be a real relief when people finally accept that. And then consider the potential burden of that screening and the potential benefits of that for individuals. So those are really important considerations when we go down this path of screening and we start to work with children and adults. Keeping in mind also, when you work with children, particularly, you have to be age appropriate in how you talk to them. And so you don't want to say, oh, have you experienced trauma in your life? I really wouldn't say that to adults either. But you have to use language like, other kids have, had the same kinds of experiences you have. And these are some of the things that we see with them when they start to talk to you. So you've got to be really savvy in terms of how you word. Words do matter, and how you word things when you're screening for trauma, because people don't want to talk about it. People are afraid to talk about it. But the goal of treatment is to take away that strong emotional and physical reaction to stressful events to where, it can just get filed away in the prefrontal cortex as this is a really bad thing that happened, but it's not going to change my life going forward. Next slide, please. So here are some traumatic stress reactions we see a lot. I'm sure you're aware of many of those. A lot of times with children, you see behavior problems. Kids sometimes do not have the language skills to tell you how they feel, but they can do mad really well. And so we see a lot of anger. We see a lot of behavior problems. Sometimes avoidance. They don't want to talk about it. And then you'll see other problems based on developmental needs and the age of the child. Next slide, please. So here's some assessment considerations. Consider the age, the culture, the developmental language, the capacities and abilities of the child. If you're using a tool, make sure it's normed and validated for that population, for that age. And what other factors might affect the reliability and the validity of the instrument. I know a lot of times when I worked in the hospital, I'd have people put kids in the hospital and they'd want a psychological, and they would want an IQ test. And I thought, when a child's in crisis in the hospital, that you don't want to do an IQ test because they're not ready to take a test. The testing process is, what does that look like? Is it comfortable for kids? How did they respond through the testing process? And words matter. Be careful on how you ask questions. Using words like trauma and abuse. My rule of thumb was never, ever, ever use the word abuse to a child until that child used the word abuse as something that happened to them. We just didn't use it. And then what types of screening tools can you use? Is it a self-report, typically ages 8 and up, where they can read and answer the questions? Caregiver completed, infants, toddlers, children under 8 or kids with developmental delays. You typically have to depend on caregivers. And then a provider completed tool. And those are usually information integration tools. Things like the Child and Adolescent Needs Assessment Screening Tool, the CANS, is an information integration tool. It's information you've gathered from multiple sources that you just pull together for that. So think about the type of screening and assessment tools that you're going to use as you begin the process, and you could bounce back and forth. Next slide, please. And now I'm going to turn it over to Jenny, who's going to talk about intervention.
So I'm hoping that's all setting the stage, and this next part too. And then I think it'll be great to have Dr. Graves on to kind of show you what this looks like in practice. But really, we wanted to go over what are some of those essential elements in intervention. Next slide. There are a lot of places that if you want to learn about the evidence base for interventions that you can look for those interventions that are related to child welfare. The CEBC, the California Evidence-Based Clearinghouse, is great. They have fact sheets you can compare side by side to interventions. They also tell you the relevance to child welfare. So there are some of these interventions that have a higher relevance, and maybe they have a lower scientific evidence-based rating, but that helps you kind of make appropriate choices. There's the National Child Traumatic Stress Network has a list of interventions, and many of our slides are coming from there. So if you're a site with the NCTSN, you may have had access to all of these things, but it is all on their website. And again, they provide great fact sheets for, educators, for, courts, for social workers, for anyone who may be involved that they have tailored specifically. The Title IV Prevention Clearinghouse also has some interventions listed there that you can look at. And then the last one, Karen and I worked very hard on a compendium of practices that is on the United for Youth website. So these were practices we really felt were also relevant to those children who had been exposed to substance use. And so that would be another place that you can look. But, if someone mentions to you that a child in your program or, someone in your community is participating in some kind of therapy and you wonder what it is, these are some of those sites you can go to see what is the evidence. Is this relevant? And how might that be working to help with the myriad of disruptions that Karen talked about in her section. Next slide. So we're going to talk about some of these elements, and as we go through them, just for you to be thinking about in your own clinic or in your own community, who might be involved in doing this? Is that person in your clinic, or are they in a service organization? One of those things is engaging clients, and many people use motivational interviewing, and that training is pretty widely available. But some assistance in helping people get through the door and engage in doing what is a lot of hard work. Again, you're going to be asking them really personal questions about their lives. They're at risk of sometimes having their children removed. One of the things we found in the OVC grants is that oftentimes determining whether or not there had been substance use in the home was difficult because people really feared that their children would be taken away from them and put into kinship care or foster care. And so engaging clients and making that a safe space and having that be a place where they understand, again, their confidentiality, and they understand why they are doing the things that they are doing. Risk screening, and I know Dr. Graves is going to talk a little bit more about this, but you saw Karen talk about the higher likelihood of suicide and some high risk behaviors. So making sure that when we are bringing kids and their families or parents or just adults into services that are trauma, we want to make sure that we're screening for those things so that we can keep them safe. And use that to triage the different levels and types of interventions. So you're matching clients to the interventions that are most likely going to benefit them. If you go on that California evidence-based clearinghouse, it gives a really nice description. You know, it'll say like for children ages 0 to 2, child-parent psychotherapy has to be with a parent. It'll give you some specific facts about these interventions that can help you see whether or not those are the most appropriate. And then we really need to take a step back in our organizations and amongst our treatment teams. If you have a multidisciplinary treatment team where you're working with other professionals, that is fantastic. But to think about what systems are they in? Their family, their school, their community. What does this case look like? How were they brought here? You know, how did it first present? That case conceptualization that's often done in supervision and around those multidisciplinary teams. And then treatment planning so that we're tailoring the intervention to the needs, the strengths, the circumstances, and the wishes of individual clients. Oftentimes clients in child welfare are court ordered to participate in therapy, but that doesn't mean that they don't have any choices. And we don't want to set that up. When we think about this whole engagement and assessment, we want to create physical safety for them. And we want to create this sense of psychological safety so that they have some control over what's going on and understand what they're participating in as they're doing it. Next slide. We want to look at, and I'm going to talk a little bit about this later on, but engagement in addressing barriers to service seeking. So is the client getting an adequate dosage of treatment in order to make the therapeutic gains? So when I was in private practice, if you're coming to see me once every 6 weeks, because my schedule is too busy and we can't get matched up, that probably wasn't the dosage that you needed if you were a high-risk client who was having a lot of symptoms or who, you know, was having some suicidal thoughts. That would have been an inappropriate dosage. So we need to look at those things and those barriers may be related to those social determinants of health. So what is their economic abilities? For kids getting to therapy, you know, is a parent going to have to take 5 buses because they don't have transportation? Seeing kids during the day was awesome, but it didn't work with school sometimes. So I got to think about that social determinant of health and think about, you know, their educational environment. Just really thinking through all of these things and how that is going to impact the service that they are seeking. There's a great article brief on the Harvard Center for the Developing Child, and I'll try to pop it in the chat when Kelly's talking about how place matters. It matters where kids are playing. It matters where people are working. The historical context of land matters. So all of these things we want to be thinking about and how they're going to impact what our treatment looks like. And some of those are specific. So I know Dr. Graves is going to talk about parent-child interaction therapy. So there's a specific setup to a room that you would need to be doing that. We want to coordinate with other agencies to help reduce some of those barriers. So to help provide transportation, housing assistance, appropriate quality childcare. When I started out seeing kids in my practice, I learned this really quickly because I left two young school-age kids in the lobby while I talked to their mom, and in 5 minutes they had proceeded to use, this is how long ago this was, the fax stamp and the copy stamp, and stamped it all over their bodies and all over my waiting room. Would have helped if I'd facilitated some childcare for their parent. Rookie mistake, but really thinking about what is it like for them to get there? Are they able to really focus on their treatment, or are they thinking about things that are going on outside of there that make it hard for them to engage in the difficult work of trauma treatment? Next slide. One of the key elements is education and skill building. So after we've set up this environment, the client or the parents or both are on target, and they understand what we're doing for treatment and what that's going to look like, and they're comfortable and engaged. And Karen mentioned this earlier, thinking about what is that psychoeducation about trauma reminders and loss reminders. What are you seeing, what's going on, helping them to understand those things, and strengthening those coping skills. So understanding what a post-traumatic stress reaction is like, understanding what a grief reaction is like. And oftentimes we're having to do this for the clients themselves and maybe family members. Myself as an infant mental health clinician, often having to talk about what is typical development and atypical development. So helping parents see that some of these things may not have been typical and may have been a reaction to the trauma. But Karen also mentioned, and I think is true, there is some relief provided in knowing that while certain behaviors and moods and feelings may not seem quote unquote normal, that they are a normal reaction to extraordinary events in someone's lives. Teaching emotional regulation to strengthen coping skills. This is not a skill that, everybody just has naturally. Some of us had great relationships with our parents, and that was wonderful. And those parents were regulated others, and they taught us how to handle our feelings. But many of us did not. And then when you add trauma as another layer on top of that, learning emotional regulation skills may be something significant that someone needs in order to progress in therapy. Maintaining adaptive routines and promoting positive adjustment at home and school. You will see when you look through many of these interventions that they require a caregiver or an adult parent to be present if you're working with kids. And this is because there's an extension beyond that office. Kids are going to be going home, and they're going to have these big feelings, they're going to have these big behaviors, and they're going to need some assistance with that outside of that therapeutic office, and coordinating and working with school to understand some of those things and what works. And really one of the engagement skills, I think, is helping clients to figure out what works and learn to advocate for themselves and say, this is what I need when this is happening. And then parenting skills and behavior management to improve those parent-child relationships and improve the child behavior. Again, this is not something that, like you're just born with and everybody thinks, everybody just knows what to do with a baby. And that is not necessarily true. And so parenting skills, understanding things like attachment relationships and our own past and how that may impact that, has a significant impact on people's treatment, both for the child and for the parent. Next slide. Some of those key elements, constructing a trauma narrative. You will see in almost every type of trauma therapy that is evidence-based, some type of a trauma narrative. So some type of a recalling of the events, the emotions, and the factors that happened, and helping them reduce the reaction to those. Karen talked a little bit about the pathways in your brain when you're having traumatic memories, but part of this is using that narrative to help reduce those reactions. And if we don't do that work ahead of time and we're just having people tell these stories over and over again, we're really doing a disservice and can actually do harm to clients by asking them to repeat things when they don't have those coping skills, when they don't have the ability to regulate those emotions, and then they're being asked to bring up those memories. Along those same lines, teaching safety skills. So how are they going to help themselves make good choices that aren't going to put them at risk? And again, from the outside looking in, we might say, well, everybody understands that that's a risky choice just to go with whoever's present and get in their car. But if you are a child who's experienced significant neglect and you haven't had a ride all the time, and sometimes you had to go home with your neighbor or whoever, that may not seem like an unsafe choice. So thinking about those safety skills and what they can do, however it was related to the trauma and outside of there as well. And teaching relapse prevention skills to maintain treatment gains over time. So as people understand their trauma narrative better, as their memory is enhanced and they start going out in the world and having more introduction to different stimuli, they may have moments where they become overwhelmed by that trauma and their coping skills don't work. They may have times like all of us where they're too hungry, they're too tired, or they're sick, and they just aren't able to cope in a way that they have before. So teaching that this happens, we all have those moments, and how do they maintain treatment and get themselves back to the place where they want to be. Next slide. System elements. So many of you may not be direct treatment providers, but you may be working in systems. And I know for my OBC grants, I had all of the wonderful legal aids and talking about advocating on behalf of the client to improve client support and functioning at school or in the juvenile justice system. Oftentimes kids get labeled, their behaviors get labeled. And I can't tell you actually how many times when I had teenagers, we would go through sometimes some of the intake information that I would get, that it was really skewed because it was written by somebody else. So thinking about all of that kind of makes a picture in a system's mind about why and how this kid is functioning and what's going on. But thinking about those systems and how we might advocate for them and what they need. Just as you might do for yourself when you're going someplace. This could include referrals to other services or coordinations with services. And thinking about how those referrals are made. So just handing someone a phone number and saying like, call and get yourself into this, treatment group might be really difficult for someone who has significant anxiety. And they may not have the life skills to do that. That might not be something they've done. So in that assessment and treatment phase, you're really helping. And then in the system phase, you're working with people to determine what are those things that are missing. Some of those could be those social determinants of health. Some of them could just be life skills that they didn't know or they haven't been taught. So thinking about some of the examples, like working with the schools to create and implement an individual education plan. With younger kids, this might be helping staff to understand what are those cues that they are overwhelmed, that they're overstimulated, and they need some quiet time, and working with the kids on a plan for how they can get to the things that they need. And referring clients to civil legal services to help with things like expulsions and suspensions at school. So I have very definitely had kids who have had behaviors that seemed disrespectful and may have been actually unsafe or seemed unsafe, that have been expelled or suspended from school when those behaviors were really a condition of them not having adequate coping skills and not having the means to control their emotions and their behavior when they had been exposed to some kind of triggering event. And those aren't always completely evident. Next slide. And then we want to continue to monitor clients. So we want to look at their progress and their response during treatment. We want to be able to correct kind of any insufficiencies and therapeutic gains that they may have, and keep working with them. You know, it is very, very difficult to change behavior. So especially when you're working with children and families together, parents may have done a great job of implementing kind of some parenting changes to help their kids feel safe, to improve those relationships, but those are hard to maintain and they take a lot of energy. And if that parent doesn't have the adequate support and what they may need, that might be one of the first things to go. And they might not be doing that. We might see some slippage back and forth. So monitoring that and making sure that we're still on the right path therapeutically. And evaluating effectiveness to ensure that this treatment really is making a difference to clients too. Do they feel better? Are they having some symptom relief? Why do they keep coming back to your office? What's bringing them through the door? And think of other stakeholders such as court systems and those that might need, you know, with appropriate releases and discussions with your clients about confidentiality, some kind of opinion from you about how they're progressing in treatment. Next slide. And then really big, and we could probably, I'm sure that Dr. Graves and Karen agree that on any one set topic, we could probably have spent 2 hours anyway, but supervision and support for those who are providing trauma treatments, for those who are doing the intakes, for those who are coordinating services, just any human being that is coming in contact with people who have experienced trauma. You want to have individual and in-house supervision. So having one big group supervision and not having the ability to have that one-on-one time is inadequate. Oftentimes people are called to and work in social services and in human services have also had their own issues, their own traumatic experiences. And while they may have done, you know, great evidence-based therapy and they may have been great, there are things that are going to tug at them in a different way. We really saw this during COVID with therapists, because for the first time, many therapists were in the exact same position their clients were in. There was a lot of unknowns. They had their kids at home with them. They were trying to manage all of that. So everybody's stress level was high. So even for those that didn't have a traumatic experience, they then now had a shared experience with their client, which could bring them closer together, but could also kind of blur the lines of boundaries and be really stressful for those providing services. Specific supervision and consultation to an evidence-based model. So if a therapist is providing child-parent psychotherapy, parent-child interaction therapy, trauma-focused CBT, these are all different kinds. There are specific learning collaboratives and continuing education that they should be receiving, because as we do more research and as our, you know, treatment of folks begins to evolve and our understanding of all of the context that goes along with treating those people that are, you know, walking into our office or in our system, we need to keep up with that research. And that would include administrative supervision and reflective supervision. So administrative supervision is the type of supervision that says, did you do a risk assessment when this person came in for things like suicide or harm of others? Did you do your treatment plan? Have we reviewed that treatment plan within the guidelines of whoever your third-party payer is and your ethics? Those are the kinds of things we do in administrative supervision. Reflective supervision is supervision that takes a look at, what does it feel like to have this person come in your office every single week and they haven't made any progress? Or this person has just told you a story about loss that is very similar to your own. Reflective supervision is taking a look at how the provider feels and how those things might be impacting them, and helping them with some of those insights. Next slide. So tiny type, which is usually a no-no for me on slides, but you really want to think about, and again, we could spend a whole day talking about how we're building resilience into the workplace. And some of that can be done through organizational means. And some of that is done through individual needs. And we talked a little bit about the individual needs, and I know Dr. Graves is going to talk about some of their resiliency work and with those that work there that includes Hope Science. And that would be both probably an organizational and an individual. So there's some that are going to cross, but thinking about trauma caseloads is one that is big for organizations. So those treating clients who've experienced trauma, you can't see 10 clients like that in a day. I know because I've tried it when I was a young rookie, and the burnout rate is so high, and your ability to give to people what they need and be physically present, emotionally present, and have all of that knowledge intact that you need to isn't there when you're seeing 10 clients a day. Same with clients in crisis. And thinking about ongoing assessment for staff for their risk and resiliency. So there's a whole bunch of things up there that flex time, offering like picnics and things like that are great, but some of these need to be like substantial time to have one-on-one supervision, the ability to practice self-care, what that looks like organizationally and individually. Next slide. And then we need to think, and Karen mentioned this, but about contextual and cultural context. And there's a citation there for the CDC for you to look at, but there are risk and protective factors for child maltreatment, which is a common type of traumatic experience. And we need to look at those. So for example, individual, family, and community risk factors that might create this risk, age is one of them. So an individual risk factor is children under the age of 4. We know this. We know that children under the age of 4 have a degree of self-sufficiency that's lower than like a 16-year-old or a 12-year-old. They need their parent for a lot of things. Babies even more are completely dependent on the caregiver for their survival. And then thinking about what are those community factors and those family factors. So a family protective factor would be someone that has a strong social network. And these are just examples, but there's a context that surrounds this. And this provides a really good list if you go and look at it for thinking about contextual factors that you might want to incorporate and think about as your treatment planning and looking at engagement of clients. Next slide. And again, those are some of those social determinants of health. They're non-medical factors. They're those things that you're born into, you grow, work, live, and age within this wider set of conditions. And they're listed there for you, but economics, policies and systems, social norms, social policies, racism, climate change, political systems, these all affect people's social conditions and their ability to participate in and gain any kind of assistance from therapy or therapeutic services or non-therapeutic services that might be more like support services. Next slide. And always thinking about, this should probably be our first slide, but those cultural things that are related to trauma. And Karen talked a little bit about generational trauma and historical trauma. There's 2 sources cited there for you to think about, but there are absolutely higher incidences of suicide among Native American youth, also among LGBTQ plus youth, thinking about racial injustice and trauma, These are all when we take on a case and we're in that assessment phase. If this is a client that you don't understand that context and you don't understand their culture, are you getting supervision? Is your organization providing for you the ability to have access to a clinician who might be able to help provide some cultural humility in the way that you're delivering your services? Or are you the best provider for them to be seen? And that's a question that we need to make sure that we're asking and assessing as we're going along. Next slide. And I'm going to turn it over to Kelly so she can give you the real world practicality of all the talking head stuff that Karen and I just did.
Well, I appreciate the background and the foundational elements that you all shared. I'm excited to share a little bit about how this plays out from referral to intervention. So as we think about becoming more trauma informed in our approaches, it starts from the very, very beginning of first contact. And as we build out a strategy to engage families in a trauma-informed way, we really have to start at that very first contact. Next slide, please. SAMHSA provides a framework for us to be thinking about how we engage with families. And so these are the 6 components that you may have seen before. It starts with safety. We always want to start with safety first, but also the importance of building in trust and transparency, peer support and how we're linking families to peers in their community, a building of collaboration, ensuring empowerment, voice, and choice, and identifying cultural, historical, and gender issues that come into play in the therapeutic process. So with this 6-point framework, we can then take these concepts and these principles and apply it to every piece of our intervention system. So if we start at that first point of contact, we look at, the first time a person answers the phone and engages with somebody on the phone or shows up at the office. Next slide, please. One of the ways that I provide an example of this is I've heard from multiple families over the years that the reason they ended up coming was because the person on the phone was just so friendly and so engaging. I've heard that from multiple people. And so it really highlights the fact that whoever's in your front office, whoever's providing that initial contact, they may not be delivering the therapeutic service, but their role in the organization and engaging the family is so critical. So I had the experience of making an appointment for myself, and I want to just share this example that I called to make an annual physical, and the person on the phone, they were fine. I called and said, calling to make my annual physical, and they said, hold please, and they kind of put me on hold. They came back and just kind of started rapid firing questions at me, like, all right, so how about March 26th at 2 p.m.? Does that work? No, that doesn't work. So they kept rapid firing dates at me. And upon finally getting to a date, they were like, okay, we'll see you then, thanks, and just kind of hung up the phone. And I thought about that example in my own experience and integrated that into what we do at Kellen with the idea that how we even go about making appointments can engage a family at the very first contact, and how different that appointment setting might be if we integrated those 6 principles that SAMHSA talks about. So somebody on the phone saying, what days and times might be best for you? I can't guarantee that I can get you in on those dates, but I'll do my best. Or having conversation around what kind of provider are you looking for? Are there a particular, do you prefer a male, a female, transgender therapist, English speaking, Spanish speaking? Again, I can't guarantee, but I'll do what I can to match you up in the best way possible. And so really even beginning that conversation at the very front end around the appointment making that helps engage a family from the very start. Questions like, what are your pronouns? Do you have preferences on how you're referred to in terms of your cultural or ethnic background? And allowing them to identify for themselves how they like to be referred to. So even at that appointment setting, we can begin to embody those trauma-informed principles. If there is a wait list, which I know across the country, there's a large demand for services, keeping them updated on their status. I know, everyone is stretched for time, but a phone call every week or 2 weeks just to say, hey, we haven't forgot about you. You're, number 6 on the wait list or whatever number they are, can help them keep in the loop on the fact that they're not just kind of a person's name or number on a list, that they're important to you, even if they're on the wait list and you're giving them updates on where they are. This also has implications for how we respond to our external referral sources, and keeping your external referral sources in the loop, thanking them for the referrals, building that connection across other organizations in the community, and working as a team to try to provide the needs that the family might have. Next slide, please. As we go from that referral to the first session, we know that there's a difference between trauma-informed screening and trauma-informed assessment. There's lots of demands on us for what we need to collect in those first sessions. And so trauma-informed screening is very analogous to how you would go to your primary care physician and get kind of your annual blood work, right? You kind of get screened for a lot of things. And if something pops up kind of positive, what happens? Well, you go back and you dig a little deeper, you do some additional blood work, et cetera. And that's how we approach screening and assessment from a trauma lens. Everyone that participates in our services has a trauma-informed screening. And if they come up positive on different types of trauma events that they might have experienced, that signals to our team that we need to go a little bit deeper in understanding these trauma events and experiences. And so we then go into more of a trauma-informed assessment to follow up with that client. And that's important because what we see very often is a lot of the clients that come to our clinic have had multiple experiences with therapy. And oftentimes it was kind of the Band-Aid approach of how, what they're presenting with at the time, but not really an opportunity to go upstream and figure out what is causing their issues from the root. And so the river analogy is one of the analogy that kind of comes into mind with that. You might have heard of that, but it's the idea that we can address the pollution at the point of when a client kind of comes into the clinic or comes in for services, and we can kind of clean that whole process up and make it look shiny. And what happens is a year or 2 years later, sometimes shorter, they begin to have a lot of disruption happening again in their life. And so the need for us to kind of go upstream and figure out what's at the root of their concerns is critical in the assessment process. And this is highlighted by the fact that of 43% of diagnostic criteria, people that met diagnostic criteria for PTSD, only 2% carry the diagnosis in medical records. So there's a huge discrepancy around how many people are experiencing PTSD and other trauma-related symptoms, and how much is actually addressed in the therapeutic process. Next slide, please. So as we think about it from a different lens, I'd just like to propose to you to take a peek at this particular picture and let us know what you see. I'll give you a second to identify what you see. You can share it in the chat box if you'd like. For many people, they'll see a rabbit or they'll see a duck. And since we're all about collaboration, I invite you to challenge yourself to see both, the rabbit and the duck. It is common nature for us to see one thing before the other, and oftentimes we have to challenge our thinking to see both. Next slide, please. In a similar way, I propose to you to answer the question about how many legs this elephant has. If we could all see each other's chat boxes, we would see multiple answers. Some people would say, I've seen 8, 7, 4, 3, right? Depending upon how we look at it, we might come to a different conclusion, right? And so next slide. And so if we think about putting a trauma-informed lens on, it really comes from this awareness that what's right in front of us may only be a part of the picture. And as we become more and more trauma-informed, it requires us to shift our perspective and look at what else might be there. There's not always just one right answer. Depending upon how we look at a situation, we may get additional layers of information that we didn't get before. So our traditional way of assessing is really just looking at what's right in front of us, right? So what, the rabbit or the duck. The trauma-informed perspective is literally shifting our perspective, looking at it more holistically and collectively to see that what is there may only be a part of the picture. And so it shifts our perspective in the assessment process from the traditional way of what's wrong with this person, what are the symptoms, what are the referring problems and all the different things that are not going well, to what happened to this person to get them to the point where they need assistance and they're showing these signs and symptoms in services. So it shifts that perspective and engages the person more holistically in the assessment process. Next slide, thank you. Using those same 6 principles from SAMHSA, The way in which we go about assessing and asking questions can be enhanced by integrating those 6 principles. So if we think about it from a safety perspective, the way somebody asks you questions makes a difference, right? The tone that they have, an explanation of why you might be asking these questions. When we think about the concepts of trauma and trauma-informed assessment, some of those questions are some of the most intimate questions you can ask somebody. And so the way that you ask them makes a huge difference in the engagement of the person, and not only the engagement, but the accuracy and the detail that you might get back. Building in that trust and transparency is critical. Sharing very clearly who you will and won't share information with, right? This is why I'm asking you, and this is who I'll share these questions, these responses with, and allowing them to weigh in on who they want information shared with and who they don't want information shared with, and making sure you're building that relationship even from the assessment process. Looking for opportunities to build in peer support. Peer support is a growing area that has been shown to be a key component of trauma-informed delivery systems, and really highlighting the fact that individuals that have experienced trauma can have deep connections with other people who may not be clinical interventionists per se, but have lived experience through trauma and trauma recovery, and building in opportunities to connect with some of those individuals in the community can help in the trauma intervention significantly. Collaborating in the assessment process, working together, taking breaks when needed, giving the opportunity to skip questions if they need to skip questions, and that comes into that empowerment, voice, and choice. And asking questions about their culture. It is, for whatever reason, I'm not exactly sure, not as common for us to ask questions like, tell me what's important to you in your culture and in your family. What kinds of things, what kinds of experiences have you had positive related to your culture and negative related to your culture? And including an understanding that these contextual factors are important to you and important to the therapeutic process, and opens up the opportunity for them to talk about their experiences. And this is important because as Karen shared, if we think about trauma as an event experienced or as harmful or threatening that can have lasting adverse effects, those 3 E's, experiences with racism and discrimination certainly can fall within events experiences harmful or threatening that has lasting adverse effects. But for whatever reason, we have not really thought about that in the context of trauma-informed approaches. And so opening up the conversation on experiences with racism and discrimination can be a key component to providing a trauma-informed response. And once we have that assessment, we're then looking at how do we select the best treatment available. And so we can use the available science and map the assessment to different profiles of evidence-based treatments. But with that, we also want to offer choice in the best options. The reality is the science has come a long way. And so it's very common to have more than one evidence-based model that might fit that particular individual or family. And so there's nothing wrong with providing the options. So for example, you may be trained in trauma-focused cognitive behavioral therapy and interpersonal therapy, right? Both of those are evidence-based treatments for addressing trauma. So you might be able to provide a description of what each of those models entails and allow the individual to select which one seems like a better fit for them. It's not the same thing, but I'm going to use the analogy of like when children are beginning to dress themselves, you lay out different outfits and they can pick their own, right? Lay out different treatment options. This is what the science says works for this particular concern. Which one feels like a better fit for you, right? And offer that choice. Next slide. This is an example of the way in which we map on different evidence-based practices for the families that we work with. We work across the lifespan, and so we're building out evidence-based specialty clinics around different target age ranges, as well as the primary uses that we might engage those treatments. So for example, we have a PCIT specialty clinic. This is for younger children, ages 2 to 7, with primarily behavioral concerns and parent-child stress. It's very relationship focused between the parent and child, and so that's a critical component. And so we may have families that come in and would be a great fit for this particular model. There's also trauma-focused CBT, which a lot of us may have heard about on the call. And so this is a past-focused model that includes a trauma narrative When I say past focused, there's a field of trauma treatments that's known as past focused, and then there's a field of trauma treatments that's known as present focused. Both of those models have a lot of research behind them. The primary difference is present focused treatments do not necessarily require or include a trauma narrative, and past focused treatments do include a focus on trauma narratives. So for example, popping down a couple lines, seeking safety is an evidence-based model that includes a focus on trauma and substance use. It's considered a present-focused evidence-based treatment in that a trauma narrative or a detailed review of a person's experience with the trauma is not included in that particular evidence-based treatment. So there's different schools of thought on what might work best for different individuals. The goal here is to provide options as we build choice for families, to provide options for what might fit that family most successfully. For some that might be on the call that are in medical settings or other brief settings where you may not be able to engage in a longer term evidence-based treatment, you might consider something like SBIRT. We use it primarily for adolescents, but it can be used for adults as well. SBIRT stands for screening, brief intervention, and referral to treatment. So this is typically 3 to 5 sessions. It's really understanding the scope of the client's concerning issues of concern as well as strengths, and then mapping on a potential treatment model based on those sessions. So that would be a model that you might engage in if you only have a couple sessions with the client. Next slide. Whatever model you choose, one of the pieces that we pays very strong attention to is the fact that it's important to not only address the trauma, but also build the positives. And we talk about resilient science and hope science related to those efforts. So trauma and resilience are not opposite ends of the same spectrum. It's a both and, not an either or. And we've spent a lot of time as a field really focusing on the negatives. Hope science and resilient science begins to challenge that by offering to us that just as important as addressing the negatives is building the positives. And we know from resilient science that resilience is built. It's just like a muscle or other skill or ability, that as we experience difficult places and spaces in our lives, we can build our resilience. And so the other thing that's important that I wanted to highlight is throughout our country, we use the word resilience in a variety of ways. And as we think about building resilience into the work that we're doing, it's important to highlight that there's different types of resilience. There's individual level resilience, which is, as described, specifically focused on the individual. So building coping skills and self-regulation strategies. There's family level resilience, which is building that social support, maybe parent-child or parent-adolescent interactions. And then there's also community and system level resilience. And the reason I wanted to highlight this is, as we think about resilience and hope science, we don't want to give the wrong impression that resilience is completely the responsibility of the individual. Resilience is applicable in multiple levels, and this includes organizational resilience too. How are we building in opportunities for wellness from an organizational standpoint as well? And this circles back to what Jeannie was sharing earlier. Next slide. One of the things that we highlight at the Kellen Foundation is that hope is an active process. We focus on the ebbing and flowing of hope. You know, sometimes we have more hope than others. Sometimes our clients have more hope at some times versus others. So we address it in that it's not just kind of this blind optimism that everything is going to be perfect and that everything is going to work out just as it's, you know, supposed to be. But we lean a lot on this quote that optimistic people see the glass as half full, but hopeful people ask how they can fill the glass full. So it's not pretending that everything is just perfect in rose-colored glasses. It's really identifying that even if it's not, these are some things that I can do to get to that point, right? So it is that active participation in working to improve a person's life and embedding that same type of approach in the therapeutic process. So they may not be there yet, but here are some things that we can do to help that person get there, right? And then beginning to parallel that for the individual experience receiving the treatment. I might not be here yet, but I can see a path on how I can get there with these steps. right? So you can kind of parallel that process with both how you approach services and embedding that kind of process with the individual receiving treatment. So that might look like access to treatment, access to positive connecting points. I might not be there yet, but I have access to these treatments. I have the ability to attend these sessions. I have the ability to access these resources, et cetera. But this also plays out in the staff, at a staff level, as well as an organizational level. That and some of the ways that we built this into our agency is by doing a staff-wide CREM training, which is community resilience model training, and integrating that into our approaches as a staff. So this creates some common language about how we address different situations as a staff. We've built in some wellness structures to where, in addition to having individual supervision on a regular basis, we also have collective all-staff meetings that some are intended for information sharing and others are intended for strictly kind of fun, upbeat, connecting kinds of activities with each other. And we also just recently hired a wellness consultant that joins us once a month to do a facilitated activity for our team to get us away from the stress and strain of the daily roles that we have in providing trauma-specific services and addressing some of that secondary traumatic stress that we might have as individual staff members. And from an organizational standpoint, I say journey approach here because we recognize that we don't always have it all sorted out as well as an organization. So creating that regular feedback loop, allowing staff to provide input on what works and what doesn't at different points of time. For example, what worked before the pandemic is very different than what it looks like now. And so being able to be flexible from an organizational standpoint and identifying the fact that, or recognizing the fact that we have what my mentor calls a bifurcated client base, meaning that from an organizational standpoint, your clients, so to speak, are your staff. If your staff are well taken care of, if your staff have the support that they need, the clients will be well served and they will see positive outcomes. And so for supervisors and organizational leaders on the call, I just want to reiterate that while your client is, is one of your targets, your staff just as much is a target to make sure that they have what they need and that they're well taken care of as well. And so with that, we build in this kind of hope balancing the scale, addressing not just the adversity and the negatives, but building in the positives in all of the approaches that we integrate. So we are right at about 15 minutes or so to the end of the session, and we wanted just to reserve some time for questions and comments about any of the content that we reviewed so far. Jeannie and Karen, do you have any additional comments to add?
My comment is to thank everybody for joining us today and to understand that this presentation will be for them, that they can adapt to their communities. We wanted to give them an additional tool. So at some point, you will get notice that this training is available for you to use. That's it for me.
Yeah, we also acknowledge that this is a little bit like drinking from a fire hose. So this is a lot of information, and some of you, we assumed knew some of it, and some of it may have been new or not relevant. But again, like Karen said, this is really just to provide something for you to take parts from, and that you could spend a lot more time on certain parts of this. I see a hand raised. So Kat, can people unmute?
I am working on it. Here we go. There we go.
Okay.
Wait.
Hi, I just had a question, and it was on the part where you were talking about how trauma is not often diagnosed. Do you know any of the reasons why that is? Like why it's so underdiagnosed, I guess?
Patricia? The reason it is so diagnosed is because frequently it gets diagnosed as other disorders, depression, those. So it gets misdiagnosed because people aren't really looking for it. And they use regular neurology. Now, if they pulled out the PTSD, obviously you could see that, but sometimes that PTSD category doesn't work well for children. And so a lot of times it gets diagnosed as other disorders.
Yeah, I just want to piggyback off of that and say that when the DSM-5 came out, the work groups that were established identified there are two most commonly misdiagnosed disorders instead of PTSD, and that was bipolar and ADHD. Those two in particular were the most misdiagnosed when PTSD was the underlying factor there. So if you actually look at the criteria for PTSD and compare that with ADHD and bipolar, remember that rabbit and the duck? Depending upon how you look at that particular situation, you could come to a different conclusion. And especially as Karen said, for kids, the criteria for ADHD for kids is maps on a lot. Think about, difficulty sitting still, can't concentrate, can't focus very well. All of those are also common for PTSD in kids. And so there's a large discrepancy there. There was a focus in the DSM-5 on creating the developmental trauma disorder. Karen touched on that a little bit, and that did not make it into the DSM-5. What made it into the DSM-5 was a subtype that's more specific for kids. But I anticipate that as the DSM continues to evolve, we'll see more differentiation of PTSD and trauma-related disorders across the age span, because it looks different at different ages.
And I think one of the other things also is the training of clinicians. In my clinical training, I didn't get any training on trauma. And so I wasn't aware. I knew trauma existed, but I wasn't aware of the full magnitude of trauma. And so if we don't continue in our learning, it's easy to miss things. And so I think that could be another thing as well that impacts it.
And I would just add, one of the difficult things about it is oftentimes we have to ask people uncomfortable personal questions, or them revealing a traumatic experience may feel like it puts them at risk of, not having their children, or, making someone else in their family very upset. So, revealing certain symptoms is sometimes easier to disclose than a traumatic event. And I have to second Kelly's, I actually had written down and I didn't use it, but for very young children I used to see kids, 5 and younger, usually, often diagnosed with some kind of attention deficit disorder. There's so many factors, right? So is it developmentally appropriate for a 2-year-old to sit still for 4 hours? Probably not. So if you're doing that and the kids are getting up and running around, then that's not developmentally appropriate. It doesn't mean it meets the criteria for that. But oftentimes we're getting a report secondhand. So someone is reporting, or a parent is reporting and saying my 2-year-old won't sit still. My 2-year-old throws these big tantrums. My 2-year-old doesn't listen to me. And it's why the idea of development itself is so important, because some of those things are developmentally appropriate for a 2-year-old. But then we map onto that, some situational factors. Maybe they get poor sleep. Maybe there's some medical issues. And then we have to think about also maybe there's been a traumatic event. So like all things, the DSM-2 provides you with a set of symptoms, right? And sometimes we miss those key symptoms that might tell us whether or not trauma has been involved. And for those clients too who don't reach that threshold, and I think Karen, you mentioned this for PTSD, that doesn't mean that trauma doesn't impact them in a way that makes their life not as full, causes problems in their functioning, their relationships. So sometimes we miss it because it doesn't fall into those certain categories either, but it definitely has an impact. But I think certainly, like I said at the beginning, one of the biggest reasons is because disclosing these things have consequences for folks, whether it's with their family or their partner or themselves and their kids, that these things are difficult to disclose.
And I think another thing in working with children, and I talked about it briefly, about using certain words that kids don't recognize as as events, and abuse is one of those words. Oftentimes if children grow up in these environments, that's just the way homes are. And so they don't recognize it perhaps as something as significant as we would. And so it gets lost in the assessment process because it's not recognized by the child or even by the family as something important that needs to come up.
Mm-hmm.
I have to add one more thing to this because this is a really good question. I appreciate you asking it. Sometimes too, it's an absence of things that that we see in trauma symptoms. So kids that don't present with big behaviors, but kids who maybe aren't developmentally on track, who don't have close relationships, those are all don'ts, right? So like they don't socialize with other kids. They're deficits that we may not notice. And that's harder to see than a kid who's having a giant, meltdown in class or who repeatedly doesn't follow instructions. So I think sometimes we miss too symptoms of those types of traumatic experiences that may involve neglect, because we're looking for the other type, the type that is going to get the most kind of response from people, where you're breaking social norms, or school rules or work rules, things like that.
And to piggyback off of that, there's a lot of research that shows that the impact of different trauma events is often delayed, that, PTSD shows up later. And I think we could see that just like if we think about COVID, for example, the impact of COVID on the workforce, in the moment, we buckle down, we do what we need to do. And then 6 months, 12 months, 18 months later, we start seeing the Great Resignation, right? And so the impact of PTSD can be delayed, and oftentimes clinicians are looking at the behavior that might be right in front of them. This kind of comes back to the river analogy, and not connecting their current struggles with what might have happened 6 months, 12 months, a couple years, however long ago, and not necessarily making those connections and addressing just what's right in front of them in the moment. So I think a greater understanding that the impact of traumas is often delayed would, I think, help serve kids and families more effectively in the assessment process.
And it can also resurface depending as children develop. You can go for a period and things seem to be okay. And I'll use sexual abuse, for instance. When children are adolescents, children who've experienced sexual abuse as young children, it can resurface again because it means something different. It can resurface again when they have their own children. So it isn't something that just is there and then it's gone. It comes and goes, over time. So it isn't very easy at times. And I think we as clinicians really need to understand all of the things that Jenny talked about, that Kelly talked about. We need to understand all those things about trauma because we could miss it. It may be there, but we could miss it.
Super easy, right? I feel like the more we talk, the more complicated it sounds sometimes. But there's a theme really of like continued learning and continued engagement and continued like not seeing and labeling people for the behaviors, but asking, what happened? Why is this showing up like this? Instead of just labeling people right away and not digging deeper and not keeping up with the research. So.
And Jenny's correct, because, you know, if you're the only therapist in a small community, you have to see everybody. But if you weren't trained to treat children, you know, getting good consultation and your own supervision is important for that, because, you know, children are not little adults. And so, you know, being able to have experience and knowledge and competency for the population you work with is really important. And that's why I think supervision for therapists should never end. You know, because things are changing, and we have to stay on top of that.
Yeah, I would add too, for cultural issues, I had a client that was not enrolled in the tribe, but the mother had made me aware of some of their cultural heritage, and we discussed it, and that was not something that I felt like I'm just proficient in this as a white person. I didn't feel like I knew enough, and I sought some consultation from, at this point, it was the Ponca tribe in Nebraska, and they were wonderful. And there were lots of therapists who could help me, but didn't see infants. So we had to kind of blend our expertise with what we had, because we didn't have what we needed to put together. But getting that consultation really, I think, served our client better than just trying to go it alone and assuming that I knew what was significant, and talking to the parent or the client.
Any other questions? If not, Kat, we'll turn it back to you.
Yeah, I don't see any more questions. So, all right. Thank you so much, everyone, for your great questions, and a few quick announcements before we wrap things up. We'd greatly appreciate it if everyone here filled out the post-event survey that I'm about to send in the chat. If you want CEU credits for this, you must fill the survey out. It shouldn't take more than 5 minutes to complete. The link will also be sent to all registered participants via email from the OBC-TTA at jbsinternational.com inbox. In order to qualify for CEU credits, you need to send your full name in the chat and email your full name and desire to qualify to the OBC-TTA at jbsinternational.com inbox and fill out this form. Or not the form, the survey at the end. Link is in the chat. The presentation recording and slides will be distributed via the OBC-TTA listserv in the coming days. Please stay tuned for future webinar announcements. And if you have any questions or comments, feel free to reach out to us at any time at OBC-TTA at jbsinternational.com. Thank you everyone so much for attending, and have a great rest of your week.